Good morning, everyone. I'll be talking to you about algorithmic approach and decision making in surgical macular conditions. Let me focus on few of the common surgical conditions like full thickness macular hole, lamellar hole, VMT, epiretinal membrane, and myopic traction maculopathy. With concern to the full thickness macular hole, many factors you need to consider. One is the age, the duration of the macular hole, etiology, of course, the most important thing being the spectral domain OCT features and the indices. Spectral domain OCT is the key investigation which helps in diagnosis, staging, and assessing the prognosis, monitoring the response to treatment, and assessing the tangential and the anterior-posterior tractions. Macular holes can be graded according to the various sizes, ranging from small hole to the giant holes. The holes which are less than 400 microns almost have got a 100% success rate, but the main concern is the worst outcome in the holes which are more than 650 microns. Various measurements you can take like inner diameter, basal diameter, height, the cystoid spaces, the macular angle, hole angle, and many things can be measured with the spectral domain OCT. So the important ones being the, as I told, mean linear diameter, basal diameter. Look for the associated VMT, cystoid changes, epiretinal membranes. With respect to the prognosis, look at the external retinal layers status, and sometimes the intraretinal cysts can be seen at the edges of the holes. So many indices have been can be measured, starting from hole forming factors, macular hole indices, diameter hole index. Some take into consideration both anterior as well as the perpendicular as well as the tangential tractions into account. But hole forming factor and macular hole indices are the two ones which take into account both the tractional forces, so are more reliable when compared to the other indices. You can, by using an image analysis, you can get both even the macular hole area index as well as the macular cystoid space area index, which have also has got a prognostic value in assessing the outcome of the macular hole surgeries. As we know, the post-surgery, it could be either type 1 closure or a type 2 closure. Some indices closely correlate with the type 1 closure like macular hole index, tractional hole index, cystoid space area index. Similarly, type 2 correlation have got a very good correlation with outer diameter and the macular area index and other indices. Please look into the external retinal layers. Sometimes in spite of a good closure, you may not get the good visual recovery because of the damage to the external retinal layers. The microperimetry, another important functional analysis, which gives a clue to the functional recovery rather than looking at the anatomical. It tends to correlate with the visual acuity, so we need to look into the microperimetry also. Coming on to the ACTA, usually the vessel density in the superficial capillary plexus is unchanged. In the deep capillary plexus is increased but returns to baseline at 6 months. Please look at the decreased vessel density in the deep capillary plexus around the macular hole, which could be contributing for the incomplete visual recovery. So vessel density in superficial capillary plexus and deep capillary plexus does correlate with visual acuity, the retinal sensitivity, and renal retinal thickness at 1 year. How does the FAZ changes? FAZ evaluation is difficult basically because of the intraretinal cysts which are present. FAZ diameter is larger than the mean linear diameter. May the FAZ reduce after surgery. FAZ area correlates with the best corrected visual acuity and the photoreceptor recovery. So FAZ enlargement biomarker for the foveal reconstruction of the surgery. So one need to look into the foveal avascular zone post carefully. The ILM peeling definitely works in smaller holes, but in a large holes, the success rate is not so high. So if you see a macular hole index of less than 0.5, larger peels probably have more than 4 disc diameter may be required sometimes than the conventional peel to get a closure of the holes. The various techniques have been described. For a smaller holes, probably ILM peeling and ILM flaps works, but if you move to the larger size holes, probably may have to look at the other adjunctive surgical maneuvers like macular hydrodissection or an insertion of an amniotic membrane or autologous retinal graft. These are the two charts which clearly shows that larger the hole, probably the ILM peeling may not be sufficient enough to get the closure and the good functional recovery. This is an algorithmic approach usually one should follow. If you tend to see a small holes, probably ILM peeling helps. If there is a reopening or the non-closure of the holes, please look at the edges of the hole. If there are just a cystoid, the flat edges are there, probably you can consider macular hydrodissection. If just in good ILM peeling done, probably gas injection or air injection sometime can suffice to closure of the holes. If it is a large hole, probably consider ILM flap, hydrodissection techniques, autologous retinal graft. In extreme cases, if there is a long axial length and other things, probably one can consider the option of scleral imbrication also. Coming on to the next entity in the macula, that is a lamellar macular. As we know, it could be either tractional lamellar hole or degenerative lamellar hole. So, do we need to tackle all lamellar macular holes? Basically, when patient has got a visual impairment, the outer retinal changes, metamorphopsia, and associated phakic status or pseudophakic, you need to look at the lens status, then we can plan for the macular hole surgery. Symptomatic patients sometimes may, with an epiretinal traction, may benefit from surgery, but look at the lens status. Sometimes the lamellar macular hole, but just by cataract surgery, one can get away with the lamellar macular holes than doing a lamellar macular hole surgery. But the concern here is conversion of lamellar macular hole into the full thickness macular hole, so you need to consider your cases carefully. Next, moving on to the epiretinal membrane, it could be either primary or secondary. Younger the age, better the prognosis. Lesser the duration, better the prognosis. Pseudophakic patients does well. Look at the metamorphopsia score also. One important thing one should look at in epiretinal membrane is the presence of ectopic inner foveal layer. The grading you can see on the spectral domain OCT, the stage 4 ectopic layers tends to do poorly when compared to the other things. It is the presence of ectopic inner layer, foveal layer, is more important rather than the thickness is more relevant. So EFL has got a poor prognosis if it is the stage 4 EFL. Then look for the central bokeh abnormalities. It is seen in most of the tractional maculopathy. They tend to inversely correlation with the ectopic inner foveal lictus. It usually correlates with the worse visual function. Then look at the macular counter. Either it can have a dome, flat shaped counter. Dome shaped macula, if you got prior to surgery, they tend to do better than the flat or a depressed sort of a macular counter. So look at the counter of the macula. Then foveal recovery, definitely earlier the foveal pit recovery, the chances of visual prognosis is good, and the patient also tend to correlate, and they tend to correlate and improve with the best corrected visual acuity and the FSZ area. All these correlates with the early foveal pit recovery. If you can see a clear space between the ERM and the ILM, then the prognosis is quite good, which has been described with the term Sukima. So you will have a greater good peel and you will have good recovery. Look at the distortion of the inner retinal layers by looking at something known as inner retinal irregularity index, which is nothing but a length of the IPL by the length of the RPE layer. So if you got this is an important prognostic marker in the ERM surgery. Even the similarly outer retinal integrity, look at all the 4 outer retinal layers, you can grade them in fact, and it also helps in assessing the prognosis. If you tend to see the outer retinal changes, probably the recovery of vision is not so good compared to if you got inner retinal changes, which are mostly recoverable. The drill, another important thing, which is an important marker which helps in assessing the prognosis of the shorter the axial length, poorer the prognosis in a patient with an epiretinal membrane. So one need to look into the axial length also. If you see a FFA in these ERM patient, if you tend to see a microvascular leak in the macular area associated with epiretinal membrane, these patients tends to do poorly when compared to the other patients. So in a OCT angiography with ARM patient, reduction in you tend to see a foveal capillary distortion, changes in the FSZ, and the vessel density changes are also. It's a positive prognostic factor for postoperative visual acuity and macular sensitivity. FSZ area, if you see a less expansion of the deep FSZ post-ERM removal, probably the visual recovery as well as the metamorphopsia score may not be the great things. The choroid, not much of relevance in ERM, but studies have shown pre-op satel AS perfusion will have a, so we'll have a prognostic, some good prognostic factors and the poor prognostic factors. You're looking at the photoreceptors, the ganglion cell layer thickness, the cost line, the external retinal layers, and the lens status, many things which gives a VMT. Basically, you should look at the couple of things. One is the type of adhesions, the visual acuity, and the thickness of the fovea at the baseline. What are the poor prognostic factor? One is the macular schisis, cystoid macular edema, duration more than 6 months, and the premacular fibrosis, all the poor prognostic factors. So small VMTs, you can observe large VMTs, associated ERM, more than 1500 microns adhesions, you need to do a surgical maneuvers. Moving on to the last entity, the vitreomacular traction, either you'll have a perpendicular forces causing macular schisis or a tangential forces causing the either lamellar or a full thickness macular hole. So what are the factors influencing the macular myopic traction maculopathy? One is the age, the axial length, the presence and size of the foveal posterior staphyloма. Macular hole with schisis type are associated with high risk of RD. Look for foveal detachment, vitreomacular tractions. But some are protective factors like reduced height of the posterior staphyloma, associated dome-shaped maculopathy, and greater choroidal and scleral thickness. These are some of the protective factors for the. We have got many treatment options: observation, buccal, vitrectomy, and scleral indentation. You tend to see a tangential traction, go for a vitrectomy with a foveal sparing ILM feeling. If you see a perpendicular thick forces, then go for a macular buccal. These are various grades which you can choose. If you move on to the grade C holes with associated with full thickness macular hole, probably you may have to look for a pars plana vitrectomy option rather than the macular buccal option. Thank you for your patient hearing.
Thank you, Dr. Sunil. And I think after this, we'll just take questions a little bit later. That was a very succinct approach to an algorithm.